Well, welcome to all of you for our last session of the day. It's after supper and at the end of the day, so thank you very much for coming. And the topic for this evening is if death draws near, biblical reflections on the end of life and physician-assisted suicide. So it's kind of a broad topic, so I have an ambitious presentation, and hopefully we'll go through it, get through the material in time. Here's what I'm going to be talking about, just a few preliminaries, including briefly introducing myself and the Bioethics Center, then some Christian principles that apply to care at life's end. Then we'll talk just briefly about euthanasia, but then we'll focus on physician-assisted suicide. I've got 4 cases for you that we'll discuss along the way. We'll go through secular arguments for physician-assisted suicide, which I'll abbreviate PAS for physician-assisted suicide, just so you know. And secular arguments against it, and then we'll finally talk about biblical reflections on physician-assisted suicide. There are some of my resources that I use, and feel free to email me if you want a list of them, kevin.voss@cuw.edu. You can see at the top of the list is a CTCR document called Christian Care at Life's End, a book by my predecessor at the Bioethics Institute, Richard Eyre, Holy People, Holy Lives, published by CPH. By the way, I'm working on my own book on bioethics. Hopefully that'll come out in a few years. Bernard Lowe actually wrote the #1 selling medical ethics textbook in the country, calling Resolving Ethical Dilemmas. Gilbert Meinlander, this book that we use in my classes, Bioethics, a Primer for Christians. He just came out with a 4th edition. And then John Pless, Mercy at Life End, a guide for laity and their pastors. In fact, here's a paper copy of it. You can find a digital copy online if you want to at lcms.org. And that was one of the products of the LCMS Sanctity of Human Life Committee. And then a textbook that I use in class. It's a secular bioethics textbook, Bioethics Principles, Issues, and Cases by Louis Fawn. Just a little bit about me. I'm actually a veterinarian. I was a large animal veterinarian, practiced for 14 years in a little town called Bondwell, Wisconsin. Unfortunately, I had to leave practice because I became allergic to my patients. So, and then the allergist had me put on prednisone. And I'm not sure if the drug caused this or not, but one of the side effects of prednisone is it can weaken your bone structure. So one day a cow kicked my right leg and broke it in 3 places while I was trimming her hoof. And that gave me time to think, and my wife and I decided that I'm going to enroll in Concordia Seminary here in St. Louis. So we moved from a town of 1,000 to the metro area here in 1995. And one time I was giving a presentation to some pastors down in Texas, and one of the pastors came up with this cartoon afterwards. Well, Dr. Voss, God used a big fish with Jonah. For your call, he chose a cow. And you can even see the anatomically correct broken leg on there if you look at this. I'm director of the Bioethics Center, which was started by Dr. Richard Eyre. It was called the Bioethics Institute. Now it's called the Bioethics Center because we offer a minor in bioethics and a graduate certificate in bioethics. Bioethics is simply the study of ethical issues in biology and healthcare. And you can see the list of things that we talk about, life issues, basically, any kind of life issues, from beginning of life to end of life and anywhere in between, including pandemic ethics, actually. And we apply philosophical and theological standards to these areas. And so we do offer, this is my little infomercial here, graduate certificate in bioethics, taught from a Christian perspective, which is unique for a bioethics certificate or a master's program in bioethics. We give participants experience in the practical application of moral principles, ethical theory, and the law. And it can actually be earned in conjunction with a master's or doctoral degree at CUWAA, Concordia University, Wisconsin, Ann Arbor. That's where I'm from. And so if you have any grandchildren or children who are attending there, they can actually get it in concert with a master's degree if they want. It's flexible, it's online, self-paced, and the cost has recently been reduced. It's a series of 4 courses: moral reasoning and bioethics, clinical issues in bioethics, which is what I teach. We actually go through a fairly hefty book called On Moral Medicine, which is a very good book. Bioethics and biotechnology, taught by Robert Fleischman, Director of Christian Life Resources. He's been writing about bioethics issues for probably about 40 years now. And then bioethics and the law, taught by a Christian Lutheran attorney. So if you're interested, feel free to let me know and be happy to send you more information about the bioethics certificate. Now, about our topic for tonight. I put a few slides in here as an introduction. I know these are kind of busy slides. I get emails from Christian Life Resources, and you can go on their website, christianliferesources.com, and sign up for these. They're free of charge. And typically a couple times a month, they'll send a little bit information about life issues. This was sent last month about Oregon's Measure 16 when it was passed way back in the 90s. Assisted suicide was limited to state residents. Well, that requirement was basically rendered inoperative. And now they allow people from all states to come to Oregon to seek physician-assisted suicide. And the writing I have there in yellow, that threatens to open a floodgate and transform Oregon into the US equivalent of Switzerland, where suicide clinics flourish. So that was quite a shocking development when that happened. This is kind of interesting. Another tidbit from a newsletter about a week later. Alzheimer's Association parts ways with assisted suicide advocacy group after 3 months. We'll talk about that advocacy group coming up. It's called Compassionate Choices, which used to be known as the Hemlock Society, or at least some parts of it were known as that. And it's interesting that an Alzheimer's Association would even partner with a pro-PAS organization. And they quickly changed their mind on that. And it said in November, Compassionate Choices put out a press release, now removed from their site, celebrating the partnership. And then at the end of January, the Alzheimer's Association released a statement saying the partnership was over and apologized for forming it to begin with, writing that Compassionate Choices values are inconsistent with those of the association. So you can imagine a group that's advocating for PAS would not be an advocate of palliative care for people with Alzheimer's disease. So just a few end-of-life issues and principles that guide all of end-of-life issues. I just want to touch on those. It's in the title of the talk. This actually, Tim Gagline talked about earlier this morning about views of personhood, and some states are actually laws protecting personhood. Personhood is basically the idea that a human being has inherent value. Society doesn't view it that way. To be a person, a human must have some sort of capability, whether it's consciousness, self-awareness, being a productive member of society, or having the ability to speak. And every ethicist has their own list. Whereas the Christian view is that all human beings, all human life has inherent value because we're created in God's image. Genesis 9:6, whoever sheds the blood of man, by man shall his blood be shed. For God made man in his own image. Man is there used in an inclusive sense. And then 3 Christian principles that apply to care at life's end, which I share with my students. That's from the CTCR document, Christian Care at Life's End. It's actually in a Bible study at the end of that document, but they're easy to remember and can be shared with your parishioners or friends. Always to care, never to kill, not to prolong dying. So the first principle, caring for the sick, has always been an important part of the Christian religion and Jesus ministry in particular. And we quite often don't have the ability to help heal people. We're not healthcare professionals. Maybe some of you are, but most of us aren't. So if nothing else, the ministry of presence is something we can do. And that's what pastors and deaconesses do, and directors of Christian education. Be with them. Be with them. And we don't know why people get sick. And some people unfortunately say, well, they must have done something wrong for them to be sick. And actually, the Lord's grace can be seen in illness. St. Paul had some sort of illness. We don't know what it was. Some people think it was epilepsy or malaria or even bad eyesight. He called it his thorn in the flesh. And he said, 3 times I pleaded with the Lord to take it away from me. But he said to me, God said to him, my grace is sufficient for you, for my power is made perfect in weakness. Therefore, I will boast all the more gladly about my weaknesses, so that Christ's power may rest on me. The second principle, which we'll discuss a lot tonight, never to kill. We should never intend or aim at death as a solution to the problems of dying, which is exactly what euthanasia and physician-assisted suicide strive to do. The 5th commandment, you shall not murder, of course, is huge. Job, which was actually discussed this evening, Job chapter 2. As you know, in the Job story where he lost everything. His wife said to him, Are you still holding on to your integrity? Curse God and die. So I gather from that, she was just saying, why don't you just kill yourself, get it over with? He replied, you're talking like a foolish woman. Shall we accept good from God and not trouble? In all this, Job did not sin in what he said. So what he's essentially saying to her, foolish just means that you know how we should handle these issues, but you're just not, you're not wise. You're not applying that knowledge correctly. And then the third principle, that doesn't mean, however, that we need to hang on to every last second of life if it's clear that God is taking that patient home. So there are circumstances where it is appropriate to allow the patient to pass if the disease is taking that patient's life. Now, these situations can be very difficult, and sometimes Christians can disagree about various cases. And as I said, I've got 4 cases for you tonight. But life itself is not our God. Mylander says in his book, Bioethics, a Primer for Christians, that we are not vitalists, meaning we don't worship physical life. So it's certainly appropriate then to let our spouse or loved one go if it's clear that the Lord is calling that person home. St. Paul writes this. He essentially says death can be a win-win for Christians, which is not the case with unbelievers. In Philippians 1, he says, for me to live is Christ and to die is gain. If I'm to go on living in the body, this will mean fruitful labor for me. Yet, what shall I choose? I do not know. I'm torn between the two. I desire to depart and be with Christ, which is better by far, but it's more necessary for you that I remain in the body. So whether we remain here on this earth or are called home to be with our Lord, we're winners either way. Isn't that kind of a neat idea? So last part of this preliminary information are some definitions. In philosophy, we call this first act of the mind, defining terms, so you all know where I'm coming from. There's a difference between euthanasia and physician-assisted suicide, both on how they're done and actually from a moral perspective. Euthanasia actually comes from 2 Greek words meaning good death. So it's a euphemism, kind of covering up what's going on there. Sometimes referred to as mercy killing, and in euthanasia, a physician plays some kind of direct role in the patient's death. Whereas in physician-assisted suicide, which is also referred to today as medical assistance in dying, or MAID, they refer to, you'll see it online. In physician-assisted suicide, a physician plays an indirect role. So a patient, typically with a terminal illness, comes to a physician, gets a prescription for an overdose of some drug like a barbiturate, and then takes that drug at home. So the physician is an indirect means to that patient's death. The patient is the direct cause of his or her death. So it's important to maintain those distinctions. Now, a little bit about euthanasia, first of all. We won't spend much time on that, but here's the first case for you. I actually share this with our pharmacy students. At Concordia, Wisconsin, we have a school of pharmacy, only 1 of 3 in the whole state of Wisconsin. A 70-year-old female with multiple medical problems was transferred to Hospital M from her assisted care center in serious condition. Under the care of an intensive care specialist, Dr. H. In the ICU, she received fentanyl, which is in the news today, 1,000 micrograms IV, which is a very powerful dose. 2,000 is the lethal dose. And that's an oral dose. This is IV. So that dosage is equivalent to about 100 milligrams IV of morphine, 200 milligrams is the lethal dose of IV morphine. She died within 18 minutes. Why? She was 70 years old and she had other concomitant medical situations. So the doctor knew that that would happen. The patient had a do not resuscitate order and no attempt was made to resuscitate that patient. So we would consider that an example of euthanasia. So euthanasia is currently not legal in the United States, but it is in several countries. Here's a partial list: the Netherlands, Belgium, Colombia, Luxembourg, Canada, and Spain. And allow what we call voluntary active euthanasia, and I'll explain that in just a little bit. However, Belgium enacted a child euthanasia law, which allowed terminally ill children, including newborns. So they are not decisional, not capable of making medical decisions, to be euthanized. And that's the first ever law of that type, condemned by the American College of Pediatricians. Just some stats. 6,361 cases of euthanasia were reported in the Netherlands in 1 year, 2019. This is before COVID. It's doubled since 2002. And we see that a lot with both physician-assisted suicide and euthanasia. Once it's legalized, every year the numbers keep going up. In fact, it accounts for 4% of all Dutch deaths. Some controversial cases involve a woman with tinnitus. Anybody know what that is? Ringing of the ears. She requested and received euthanasia for ringing of the ears, and one woman was an alcoholic. So not terminal. So you can see how things kind of the rules seem to bend after a while. Here are the 4 main types of euthanasia. I debated whether even to include this slide because it's kind of busy, but it's very informative. First of all, some definitions. There are 2 different types of euthanasia based on the status of the patient, voluntary and non-voluntary. So voluntary is when we have a decisional patient, person capable of making medical decisions, ask for euthanasia from their physician. Non-voluntary means we have a non-decisional patient. So I always tell my students, remember this: non-voluntary, non-decisional. And then we have to involve a surrogate to actually ask the doctor to end the patient's life. And then we have 2 types of euthanasia based on how it's carried out: active versus passive. Active is what most of us think of when we think of euthanasia, where the doctor actually ends the life of someone, typically by means of a lethal injection. Passive euthanasia is where a patient's treatment is ended inappropriately, and I want to highlight that word, inappropriately, thereby ending that patient's life, not because of their illness, but because of the withdrawal of their treatment. So we can mix and match those 4 definitions on that chart on the right. Voluntary passive euthanasia is where a decisional patient, voluntary, asks a doctor to withhold or withdraw treatment, passive. Happens every day in the United States. That's legal in the United States. Non-voluntary passive euthanasia, a surrogate of a non-decisional patient asks a doctor to withhold or withdraw treatment. That also is legal in the United States. The Terry Schiavo case, you might remember from several years ago, would be an example of that. Voluntary active euthanasia. So we have a decisional patient who asks a doctor to actually end their life by means of a lethal injection. That's legal, as we said, in the Netherlands, Belgium, Luxembourg, Canada, and Switzerland, not in the US yet, but there are organizations trying to get that legalized. And then we have non-voluntary active euthanasia. So a surrogate of a non-decisional patient asks a doctor to directly end the patient's life by the means of lethal injection. And for years, I would say on this chart, when I show it to my students, not legal anywhere. Well, that has ended. Childhood active euthanasia is legal in Belgium because children are non-decisional by definition. And for severe dementia, people with dementia also are not decisional. In the Netherlands, illegal everywhere else so far. A little bit about the difference between active and passive euthanasia. This actually comes from that book by Vaughan. Some contend that the distinction is crucial. Active euthanasia is killing, but passive euthanasia is letting die. I would argue with that distinction, but that's how some people see it. The American Medical Association has sanctioned that distinction. Some argue, however, there's no morally relevant significant difference between mercifully killing a patient and mercifully letting the patient die. So some people, for example, who are pro-euthanasia and pro-PS would say there's no distinction. We should be able to do both. And I think most of us would actually be on the other end of the spectrum where we would be concerned about both, especially if we define passive euthanasia as inappropriately discontinuing treatment, ending a patient's life. How about the result from case 1? You're probably waiting with bated breath to find out the result. More than 24 wrongful death lawsuits were filed against Dr. H and Hospital M. Dr. H's license was suspended, but he has not yet been charged with a crime. Nurses and pharmacists were also named, but charges against them have been dismissed. State board actions against those nurses and pharmacists are still pending as of 2019. And so we would consider this to be an example of involuntary euthanasia, which I didn't discuss with you yet. Involuntary euthanasia is when a patient does not want to be euthanized, but it's done anyway against their will. Classic example of that is Nazi concentration camps where Jews were euthanized against their will. So this would even be more extreme, involuntary, active euthanasia. 5 patients were treatable, not terminal. So they certainly did not want to be euthanized. So that's the first case, and that's euthanasia. So now we're getting to the heart of this talk, and that is physician-assisted suicide. I've got my hand out here just so I know where I am in my talk here to see how much time we have left. Also called medical assistance in dying, or MAID. And so physician-assisted suicide is defined again as taking the patient's his or her own life with the aid of a physician. And the American Medical Association has denounced PAS. The American Nurses Association caused quite a stir in our faculty, among the nursing faculty. They seem to be more amenable to allowing it. Some of the wording in some of their resolutions seem to waffle in that regard. Many people, including some physicians, support its use, and today it's legal in 11 jurisdictions in the United States. And you can see those. I'll read them off for the benefit of those who are online. California, Colorado, District of Columbia, Hawaii, Montana, Maine, New Jersey, New Mexico, Oregon, Vermont, and Washington State. And Canada, it's also legal. And Ontario providers have administered 13,372 deaths since MAID was first legalized in 2016. We're fighting an uphill battle, however. If you were to do a survey, this is an example of a 2018 Gallup poll. They asked, when a person has a disease that cannot be cured, do you think doctors should be allowed by law to end the patient's life by some painless means if patient and his or her family request it? And yes, 72% of people agreed with that, no 27%. Here's the organization that's trying to get physician-assisted suicide legalized in every state, called Compassionate Choices. And they have, actually, you can look online. They don't hide it, compassionatechoices.org. There's their battle plan. So you can see that the states in light blue are states where, as they call it, medical aid in dying was legalized. The dark blue states, including Minnesota and Iowa this year. I just took it off the website a couple days ago. It's hot off the press. They have medical aid in dying legislation pending, not Wisconsin this year, ironically. Every year in Wisconsin, every other year it actually comes up. It's voted down, but they keep bringing it up every other biennium. Same thing with Minnesota. And then states with compassionate choices organized volunteer efforts are the yellow dots. Look at how many yellow dots there are, where they have actually organized. So we need to get organized. I think someone said that, Tim Gateline said that this morning. We need to get organized. They're organized. Here's case number 2. Deciding whether to fill a lethal prescription. Pharmacist Mo Jameson believed a person had a right to choose his or her own manner of death. Physician-assisted suicide is legal in his state. And so he believed that pharmacists should play a role in the selection of the dose of drug used. So they should play a role, in his opinion. He also believed that pharmacists should be informed about the intended purpose of prescriptions and not just fill the prescription, but realize, oh, this is for physician-assisted suicide. So he believed pharmacists have a right to know what the prescription is for that the physician writes. So then they can decide whether they participate or not. Once the patient arrives, however, the pharmacist, Mo, has second thoughts about dispensing and counseling the patient. And that's quite common, in the pharmacy realm, because they are actually morally implicated in physician-assisted suicide. They're indirect causes of the patient's death as much as the doctor. And that troubles several of our pharmacy students, especially if they live in states where PAS is legal. Let's look at Oregon's Death with Dignity Act. It was the first law passed legalizing physician-assisted suicide. And it's interesting looking at this law and how it's changed over the years since the 90s when it was passed. The patient must be adult and decisional. State residency requirements, however, have been removed. As I said, they used to require you to be a resident of Oregon, no longer. The lifespan of the patient is expected to be 6 months or less. That also has been expanded to 12 months. 6 months is typically the hospice restriction on funding hospice. So they expanded it to 12. The prescribing physician is protected from liability, getting sued either civilly or file criminal charges against that provider. A second physician's opinion is needed. There has to be a written request and 2 oral requests. And they at first required a 15-day waiting period, or time to think about things. But that was also eliminated in 2019. Counseling is required if a doctor deems the patient to be depressed. However, data show that doctors are very poor at diagnosing clinical depression. We'll see that in the data coming up. So here's some statistics. The new data should be coming out any day now for 2022. But 238 patients died due to the Death with Dignity Act in 2021. 383 prescriptions were written, and comparable to the year before. Here's a troubling stat, which I have in yellow. Ingestion status is unknown for 106 patients who received a prescription in 2021. And that might be for various reasons, but those drugs actually have a pretty good street value. And you wonder what happens to all those drugs. Since the Death with Dignity Act was passed in 97, the total number of patients who have died, 2,159. The median patient age at death was 75. 97% were white, so a vast majority were white. Typically, minorities do not participate in these programs in general because of their suspicion of our healthcare system. 46% had at least a bachelor's degree, so pretty well educated. Now, you might ask, why are they doing this? And the Oregon Public Health Division publishes this data. They actually do surveys of patients who undertake physician-assisted suicide, and you would think it would be fear of pain would be at the top. Actually, it's not. Loss of autonomy, 93%. Decreasing ability to participate in enjoyable activities, 92%. And loss of dignity, 68%. 2 patients out of all those hundreds who received a prescription were referred to psychiatric counseling in 2021, 3 in 2020, if you think that's just a recent trend. 1 in 2019 and 3 in 2018. One would think, just rationally, that there would be more of those patients that perhaps would benefit from counseling, but they're not referred. A total of 133 physicians wrote prescriptions in 2021 out of an estimated 14,000 licensed physicians. So it's a very small number of physicians who actually participate in this. Here's a chart actually published by Oregon in 2022, and you can see the general trend of prescriptions written. That's the top green line. And then the bottom purple line is actually the deaths. So you can see that other than a little blip during COVID, it's been going up and up every year. One can see a dramatic increase, if I could, I'd show it to you. In 2014, you see a jump in both prescriptions and in deaths. Why is that, you might ask? Brittany Maynard. Perhaps some of you heard of Brittany Maynard. So this is case 3. Very articulate woman, spunky, adventurous spirit. Discovered she had inoperable brain cancer. She was late 20s, early 30s, so fairly young. She died in 2014. And she posted a video online that had millions of hits. And this is one quote from that video. The reason to consider life and what's of value is to make sure you're not missing out. Seize the day. By the way, Robin Williams had taken his life that year, and he was in the Dead Poets Society. Remember that movie? And then that was one of the famous phrases from that movie, seize the day. Seize the day. What's important to you? What do you care about? What matters? Pursue that. Forget the rest. She apparently was not a very religious person. And actually, Maggie Garner knew that. So we'll see her response in a little bit. So what are some ethical theories and approaches that actually support physician-assisted suicide and euthanasia, for that matter? And that is patient autonomy. Number 1, I have the right to say what happens to my own body, the right to self-determination, seize the day. Compassion, mercy, for those who might suffer or expected to suffer. We give that a fancy term, beneficence in healthcare, doing good. Utilitarianism, that's an ethical theory that believes that whatever act I select, it should result in the greatest good for the greatest number. So with physician-assisted suicide, less money spent, people don't have to be burdened anymore, including the patient's family. Society will be better off because we can devote money maybe to more vaccination programs instead of spending money on end-of-life cases. So utilitarian generally supports physician-assisted suicide. Then we get to our last case, Maggie Carner. Many of you know her, knew her, and former director of LCMS Life Ministries and the chair of the LCMS Sanctity of Human Life Committee. She was diagnosed, ironically, with the same cancer as Brittany, glioblastoma multiforme was called, terminal brain cancer. She died of her cancer in 2015, actually after participating in a clinical trial, which actually, I believe, lengthened her life by several months. Amazing things that they're doing with brain cancer these days. Even using the polio virus to treat brain cancer. Can you believe that? Sadly, she did die in 2015, and she appeared in a video, a letter to Brittany, maybe, and you can still see it on YouTube, providing reasons why Brittany should not take her life. She also wrote an article in the Federalist called "Brain Cancer Will Likely Kill Me, but There's No Way I'll Kill Myself." That's typical Maggie. That's just the way she talked. However well-intentioned, this is one area where the old adage that hard cases make bad law come into play. To make good policy decisions about assisted suicide for our society, we need to follow the rabbit trail all the way down the hole to see where it leads. Marilyn Golden, a senior policy analyst for the Disability Rights Education and Defense Fund, warned that assisted suicide is not progressive. In fact, it puts many vulnerable people at risk, and we have already seen examples of that where it's legal. Folks concerned about the rights of people with disabilities, like Alzheimer's patients, are worried about this, and they indeed are. So what are some objections against physician-assisted suicide? First of all, secular objections. An author, an ethicist by the name of John Aris, wrote a very nice article called "Physician-Assisted Suicide: A Tragic View," where he analyzes both sides of the issue. And he says he grouped those who are opposed to it into three factions or groups. The first faction objects to the fact that physicians are involved. From the original Hippocratic Oath, neither will I administer a poison to anybody when asked to do so, nor will I suggest such a course. The second faction doesn't necessarily oppose PAS in principle, but it has reservations because of social consequences. So autonomy and mercy, often referred to as the two pillars, the two strongest arguments for PAS, make it highly unlikely that society will stop with modest proposals of PAS. Have we seen that? Yes, Oregon. And in other countries where euthanasia is legalized. The likelihood of abuse, neglect, and mistake is another societal concern. For example, discrimination against the disadvantaged and the handicapped, mistrust by minority groups because they feel they're the ones who'll be pressured into doing PAS because it's cheaper, less fuss and muss, less than fuss than palliative care. The inability of primary care physicians to correctly diagnose and treat depression. Ooh, the data seems to point that out. Difficulty monitoring PAS, the number of cases where we don't know the outcome, and a negative impact on hospice programs. Hospice programs, which many of them receive funding through Medicare, are worried because if the government decides to cut funding to Medicare, guess what? Maybe they won't support hospice anymore. They'll direct patients who are elderly or maybe with dementia into physician-assisted suicide to save money. So hospice programs are generally worried about this. Then we get to the third group where probably most of us would fit. The third group or faction opposes PAS on religious grounds. So now we're into the last part of our presentation. In society, death is natural. That's the way people see it. It's just a part of the circle of life. Where does that come from, that notion? Anybody hear that before? Death is just a part of the circle of life. Disney, right? One of the most ethical organizations on the planet, right? The Lion King, right? Lion King. It's actually an ancient pagan idea. And Eastern religions support it too. But on the other hand, the Bible refers to death as an enemy, the result of sin, defeated at great cost by our Lord on the cross. Society tends to see death only as an aspect of science or biology, not as a spiritual matter. And here's a quote from my predecessor, Dr. Iyer, which is quite a thinker. Since suffering cannot be thoroughly addressed by modern medicine, some people feel the best way Okay, the best way to get rid of suffering is to eliminate the sufferer. Isn't that kind of sad? If we can't stop death or dying, or we can't stop suffering, let's just get rid of them. And it's a crass way to say it, but seems to be true. Here's another quote from Maggie. Again, this is her talking. I can just hear her saying this. Death sucks. And while this leads many to attempt to calm their fears by grasping for personal control over the situation, autonomy, as a Christian with a Savior who loves me dearly, who has redeemed me from a dying world, I have a higher calling. God wants me to be comfortable in my dependence on Him and others, to live with Him in peace and comfort no matter what comes my way. As for my cancer journey, circumstances out of my control are not the worst thing that can happen to me. The worst thing would be losing faith, refusing to trust in God's purpose in my life, and trying to grab that control myself. So is that really death with dignity? Is PAS and euthanasia death with dignity? John Pless writes, the two chief arguments for PAS that are hug at heartstrings, autonomy, and mercy are very strong. However, is that how we find death with dignity? Easter robs death of the dignity it claims for himself, Dr. Pless writes. We're freed from the mythologies of our culture that would seek to give us power over death. Easter gives us something far better. Easter gives us a sure and certain word: Jesus died for your sins. God has raised him from the dead. The grave cannot hold him, and neither will it be able to keep those who are his. Gilbert Meilander writes specifically about PAS. Christians have held that suicide is morally wrong because they've seen in it a contradiction of our nature as creatures, an unwillingness to receive life moment by moment from the hand of God, without ever regarding it as simply our possession. We're dependent beings, and that's something he stresses throughout his book. And to think otherwise, to make independence our project, however sincerely, is to live a lie, to fly in the face of reality. And in case you're wondering, what is the official LCMS stance on it? I know this is actually a snapshot right out of the convention resolutions, 14-08A, 2016 Synodical Convention in Milwaukee. Actually had a very in-depth, John Pless actually had a role in writing this, and I provided some input too. The LCMS resolved that the LCMS continued as a strong voice for the sanctity of life, especially supporting the truth that is life, that life begins at conception and continues until natural death, and therefore deserves our protection and care. And be it further resolved, the LCMS continued to oppose physician-assisted suicide and euthanasia. So the LCMS is on record in our convention, other than the Bible, our highest authority, as opposing PAS and euthanasia. And the third resolve says that pastors and congregations should be encouraged to utilize resources concerning care at the end of life, which have been developed by the LCMS, and then it lists the pastoral care companion, which Reverend Pless talked about, Preuss just talked about last session, by the Commission on Theology and Church Relations, Christian Care at Life's End, which you can find free online, and then Mercy at Life End, the book that I just recommended to you. Resolve, pastors and congregations be aware of and respond faithfully to legislative and judicial rulings that call into question the value of those lives rendered burdensome by disease, accident, or age, and be it finally resolved that pastors will seek opportunities in their teaching and preaching to address end-of-life issues in such a manner that members of our congregations are prepared to think and act biblically when faced with decisions at the end of life. And I'm hoping that that group here, you who are movers and shakers in this area, do whatever you can to get your districts and your congregations to talk about these issues more. They're quite often not talked about. They're just kind of glossed over. Pastors need to be preaching about these issues. They need to be offering Bible classes. They can invite people like Tiffany, for example, or me, or Michael Salomonic to come in and give a talk. That's what we're here to do about these issues. So if pastors don't feel they know enough about it, invite us in. We're happy to do that. And just so you know, the Roman Catholic perspective, very similar to the LCMS, so we partner with them. in that. This is a quote from their ethical and religious directives for Catholic healthcare services, which is their kind of moral authority when it comes to Catholic healthcare services, which are about 20% of all healthcare services in this country. Paragraph 60, it defines euthanasia as an omission that of itself or by intention causes death in order to alleviate suffering. Catholic healthcare institutions may never condone or participate in euthanasia or assisted suicide in any way. Well, what are some alternatives? They don't just leave it there. Dying patients who request euthanasia should receive loving care, psychological and spiritual support, ministry of presence, right? And appropriate remedies for pain and other symptoms so that they can live with dignity until the time of natural death. So we can kind of join forces with them about this issue. Other religions might interest you. Also opposed to PAS, Orthodox, Episcopalian, Assemblies of God, Mormons, Evangelical Lutheran Church of America, Wisconsin Evangelical Lutheran Synod, Presbyterians, Reformed, Salvation Army, Seventh-day Adventists, Southern Baptist Convention, and Methodists. So we're not alone in this area. Partly in favor, Church of England accepts passive euthanasia, but not active. Islam is in general opposed to euthanasia as contrary to Islamic law and holy texts. Judaism, passive euthanasia was declared legal by Israel's highest court. Active euthanasia is still illegal in Israel. And so that's my talk. There's a picture of me with Maggie in January 2015 after she received her honorary doctorate from Concordia Theological Seminary in St. Louis, and well deserved, by the way. So that's my talk. We maybe have a few minutes for questions, but thank you very much for inviting me to come here, and hopefully talk was helpful for you. Any questions? How many minutes do we have approximately? 3 minutes? Oh, okay, enough for maybe 1 or 2. Any questions? Yes.
So what would be inappropriate treatment as opposed to appropriate?
That's where the ethics gets difficult, and it's hard to lay down a solid, fast rule on that. My lander actually offers 4 guidelines for that. One of them is if the treatment's futile, meaning it's useless, and that's ingrained in medical literature. If the burdens of the treatment far outweigh the benefits, not just a little bit, but far outweigh the benefits, then he would say it might be appropriate. Our aim should not be death in this case. Our aim should be care for the patient. So those are a couple of the guidelines that he offers. So so some are kind of ingrained in medical literature, some are just commonsensical, but every case is different. You know, every individual case is different. So pick up his book and, you know, read that chapter, and, you know, you'll get more information. Anybody else? Just stunned you all. Okay, well, thank you very much. Thank you.